Okay, so I have the luxury of being the moderator for the session, which means that I can pick on my colleagues in the way that I want. I've been fortunate to have known most of them for decades or more, so it's been quite an interesting journey. I was going to actually start with a question that I wanted to ask Joe. I apologize. I know I'm not a patient, but I just thought I'd be, we have somebody who I think all of you know extremely well, but one of the things that I've always struggled with is this issue of care that happens across the world and how it can change, depending on where you live. And Joe has had the luxury of working for a number of years in Canada, working at the Mayo Clinic, which I think all of us see as a beacon of multiple myeloma, and now moving on to the IMF, where he continues to treat patients with myeloma, but they don't go to the Mayo Clinic. And maybe could you very succinctly just tell us what you think has been the difference in the three areas that that you've done clinical practice?
It's a fascinating question. I could bore you ad nauseum all day talking about it, but I mean, a beautiful part of it is that the patients are the same wherever you are. And I'm not just saying that to sort of a feel-good, let's hold hands, sing Kumbaya moment, but it is true, right? Whether I'm in the favelas of Brazil, which I was a few weeks ago, or in the ivory palace, as it were, of Mayo Clinic, patients are the same, right? Patients, no matter what people's socioeconomic background is, no matter what people's ethnic background might be, myeloma is still the same hideous disease that we treat. So I think there's more. It sounds like I'm running for office or something, but there's more to unite us than to divide us. Is really the point when it comes to myeloma, and this was a massive motivator for me to join the IMF, because I want to have a global impact on myeloma. I mean, I want to work with people like Aldo in Canada, and well, there's no one like Aldo exactly, but his equivalents across the planet, so that we can really come up with something unique. That being said, I think, Kevin, what you're getting at is that, in Canada there was, and my Canadian genes that get turned on when I talk about this sort of thing was, although there are some restrictive access-like issues in terms of seeing patients, insurance isn't an issue, right? And people can go and see their practitioner. Obviously, access to drugs is a whole other discussion and topic. And so I love that part of it. I loved that at Mayo, my role was a little bit different in that about 50% of the patients that I saw were coming from out of state to see me. So people would fly from all over the country or the world, frankly, to come and get that second opinion. Although I must say, and I don't speak it in any way disparagingly of Mayo, because it's an extraordinary organization, but it's part of the reality of U.S. healthcare is that there were a significant number of patients that couldn't see me because they had unusual kind of insurance. Now, Mayo really tried to expand that, include Medicare and so on, but I've really just learned, even since leaving, there's a group of oncologists in Phoenix that came to me and said, Joe, about half the patients we wanted to get in to see you, we couldn't get in. And that was part of the motivation to be involved in the clinic that I now currently have set up, which is through a regional cancer center in Scottsdale and in Phoenix, through the organization that's City of Hope Cancer Center that's based in LA. They have an affiliate in Phoenix where my office is at what's called TGen, or Translational Genomics, where now I have that sort of wide open access. So I feel a little bit Canadian again, It's great, eh? Dem Jets, eh? They're playing great, eh? Dem Jets, I remember going to Winnipeg and they would tell me that before, when the Jets were last place, they're playing great, eh? I'm like, oh. But now they are playing great, so we'll give it to them. But so it's fascinating to me, because you do realize that, I know sometimes here we feel very frustrated that we can't get certain drug access, but it is universal wherever you are in the world that there's a problem with healthcare. There's no perfect healthcare system. I meet with my friends in France and in England, and Chris has lived in England for a period of time and worked in the NHS system and understands it. There's no perfect system, but I have learned at the end of the day that removing whatever barriers we can for people to have access to information, care, and as much as possible drugs clearly has an impact on their outcome, because we've been able to show unequivocally people with very compromised insurance in the U.S., for example, really have disparate health care. So the spread of health care in the U.S., sadly, is really quite dramatic, as opposed to in Canada, where We may sometimes feel frustrated that we don't get certain aspects of our care. It's a lot more homogenous. So I don't know if that answers your question or not.
I think it certainly helps, and this goes on to the first question that I have in my hand. And once again, it's to you. It's that in traveling globally, where do you find the most progressive treatments? And is this helping expedite approval in other places, including Canada?
I mean, it's a great question. I mean, in many respects, we always think that everything happens faster in God bless Merkel. And in many respects, things do move faster in the United States, but not always, you know. So daratumumab that you heard a little bit about today and hear more about, which is that monoclonal antibody drug, got its approval in frontline treatment in Brazil before any other country in the world. So it really depends. You know, in terms of progressive thinking, I would suggest that it really depends on the system. In America, there's sort of a more wide open door. Like drugs get approved more quickly with, if you will, less stringent evidence. In Canada and Europe, the standard is much higher, and there's a greater emphasis on the pharmacoeconomic side of things. Like, not only is this drug safe and effective, it's cost effective. That's the trinity of drug approval, right? Is it safe? Is it effective? Is it now cost effective? Whereas in the US, there's more focus on the top two. Just, is it safe and is it effective? We can deal with the cost later. And then as we look outside of that in other countries, very often it's driven by advocacy groups within the country, or frankly the pharmaceutical company. If the pharmaceutical companies really, like, if you saw what goes on, for example, in Latin America, there are a lot of countries where you'd be surprised that, you know, pomalidomide is approved in Colombia, but lenalidomide is essentially still not approved in Uruguay. How can that be? So they often have to go to the markets where they feel that there's going to be, it's worth their while. And I'm not saying they're financially driven only, they're driven by lots of other regulatory issues, and it's understandable. You know, if you're going to bring anything to market, whether it's a drug or an Oreo cookie, you look to see what is your audience, what is it going to be like. Last point I'll make is that one of the beauties of working at the IMF is that we see this incredible expertise around the world. You know, you heard from Jens Hillengast this morning, who comes from Heidelberg in Germany, which is really a major center for advancement of imaging, right? Flow cytometry, where we can look at the outside of cells, is really unparalleled in Spain. Blood DNA analysis is really extraordinary in Australia. And honestly, from the work that we've just heard, I think Canada in many respects is going to lead the way in database management and being able to access large numbers of patient information to look at outcomes of different treatment strategies, because there's more, if you will, homogeneous treatment of patients in Canada compared to others. And it's that sort of United Nations of myeloma that is ultimately, I think, going to leverage the benefit of each place to I think, bring us to a closer to a cure.
Thank you, Joe. As I do have a lot of questions, I'm just going to, you know, I guess ideally I would have all three of you comment, but I'm just probably just going to direct the questions to one or the other of you. So maybe I'll ask Chris this question, which I think is a really relevant question because it's more of a practical issue. So this question, just to paraphrase, is that for patients who are not transplant eligible, if they have a treatment and they're doing well on their treatment, like for instance having a VGPR, and they're going to continue on their treatment, as we now typically have patients on continuous therapy, what are your thoughts regarding trying to adjust their drugs to maintain their response and to maintain their quality of life? And this can include things like maybe drug holidays or whatnot, or things like that.
I think that's a crucial question from a patient's perspective, because it's easy for us to just write the chemo order and say, see you next month. But every time we write that chemo order, there's a consequence to that. And unfortunately, I guess fortunately and unfortunately, fortunately the data that we have out there shows that with, you know, ongoing continuous therapy, we've made great strides in the outcomes for patients. We can control their disease for longer, and that has an impact on disease control and also on overall survival. But the trade-off is that you need continuous therapy to do that. It's full acknowledgement of the fact that we can't cure this disease. So success then ultimately, at least based on the protocols that we have, requires us to figure out a way to keep you as patients on the treatment for as long as we can. And this is, I think, where the art of medicine comes into play. Every patient is going to be a little bit different with how they tolerate a given regimen. They carry different, prior medical baggage to that. It depends on their line of therapy that they're coming into it as well. So I'm a great advocate for, first and foremost, keeping patients on therapy if it's feasible and reasonable, but then also working with patients to try and figure out how do we maintain you. And I also fully acknowledge, though, that this whole idea of continuous therapy is not at all costs. And if we are crossing that threshold where the treatment is worse than the disease, I think it's a moment for pause and to say, is it really worth it at this time for you as an individual patient to carry on with what we're doing? And is that trade-off from a quality of life standpoint really worth it? And as much as we are advocates, or I'm an advocate of continuous therapy, I have many patients where we just say, now's a good time to just stop and let the chips fall where they may. We have other things in our back pocket that we will eventually be able to go to, and we have, many of you in the room will be on your 4th, 5th, even 6th line of therapy perhaps in their disease. So we know that, quote unquote, failing on one line doesn't necessarily mean that everything is over. We have many other things that we can go to. So I hope that kind of answers the question.
The next question, I guess I'll pass on to Dr. Bergstrom. And this question is really regarding second transplants, particularly in the relapse setting. So what is the advantage, or is there an advantage, and how do you choose to get a second transplant versus using drugs in the setting of relapsed myeloma?
There's a lot of things that go into answering that question. I think it's fairly center specific to some extent as far as how the physicians feel about it. So second transplants are maybe more embraced at some centers where maybe looking at a change of therapy, especially depending on what's available. For instance, a clinical trial might influence whether you'd get another transplant versus a therapy. As well, your duration. So if you had a transplant but you only had a few months really before you started to get disease progression, another transplant is probably not going to buy you that much time. Again, that goes back to, if you've had a therapy that has been extremely effective, revisiting that might make sense. If you have any therapy really that's not been as effective, revisiting that might not be as useful. So I think if you only had a short duration of response to transplant, most centers would say, and short being anywhere certainly less than 1 year, maybe even less than 2, considering what you go through with a transplant. Anything less than that probably doesn't make sense to go there again. It would make more sense to go on to another therapy that might be more effective. And some of that is patient preference too, because there are some people who did great with their first transplant as far as their response and their duration and then how they did. And then you suggest when they start to progress, we've got the cells saved, you could have a second transplant. And they say, yep, no. And that's, and again, that's why you have these discussions with patients. At the end of the day, I'm not treating a machine, I'm treating a person who has very definite experiences and opinions, and so at the end of the day, we're going to also be influenced by what the patient wants when it comes to the direction of treatment. So I think there are a lot of elements that would go into answering that question, but I hope that provides a little bit of insight.
Okay. The next one I'm going to pass back to Joe again, if you don't mind. So, a very important topic that's not necessarily the most sexiest when we talk about myeloma and relapsed myeloma is obviously the bone health and bisphosphonates. And that's evolving quite a bit as well, too. So there's a couple of questions on this. As you know, the early studies were on patients who are newly diagnosed who got pamidronate or zoledronic acid. But with patients that are living now 5, 10, 15, 20 years, I guess this question is really, should patients be maintained on some type of bisphosphonate continuously, endlessly, or is there a start-stop? What are the strategies? Is there a benefit if you've been getting bisphosphonates for 6 years continuously? What do you do?
No, great question, and one where we don't have real consensus in the myeloma community. This is one of the questions where you put 20 myeloma doctors in a room and you have 25 opinions, right? It's very challenging. I think generally the strategy that most of us would follow, and there's some variability now, because we have to appreciate the fact that myeloma is different now than it was when a lot of these studies were done, where people basically received 2 years of continuous bisphosphonate therapy. Those are the days where myeloma clinic, everybody was coming in hunched over because they had fractures, the burden of bone disease was heavier. Not that it isn't heavy now, but we're now with better treatments getting people into a deeper remission more quickly. So some people have adjusted that calendar to a shorter period of time. But in general, for that initial bisphosphonate treatment, most people would say they should get it monthly for at minimum 1 or up to 2 years. And then there's usually a 3-step algorithm, meaning 3 options. Option number 1, someone still has a lot of bony disease involved. Their myeloma itself may not be under very good control. We may elect to continue it monthly and then just constantly reassess. The intermediate option, where many of our patients now land, would be to say, look, your myeloma's under control, but you did have, bone disease. It may come back again at some point. Let's keep you on a bisphosphonate, but every 3 months instead of every month, so it's more convenient. We know the drug, after a while, actually does build up in your system, and so giving it to you every 3 months, although we don't have great evidence for it, may still be protective. And then the third group, we might say, let's just stop entirely. Your myeloma's in great shape, and there isn't active bone disease right now. Always remembering that at time of relapse, we may reinstitute it. The 2 variables in all of this is this whole notion of osteonecrosis of the jaw that some of you may have heard of, this idea, the sad side effect of bisphosphonate use where people can actually get significant damage to their jaw. I have to say that I think we're seeing that go down quite considerably, partly because we're more careful now to have someone see a dentist before they start a bisphosphonate, and we're more aware to pick it up. I actually personally believe that there was some bad batch of drug for a period of time, because it seems like we're seeing so much less of it, so it's perhaps less influential. By contrast, we now have 2 large long-term studies of giving myeloma patients bone disease drugs. One of them was bisphosphonates, and one with a new class of drugs called denosumab, where actually there's evidence that in the long term it not only protects their bones, it may keep their myeloma in remission for longer, if not even affect their survival. We're still contemplating why that is, but that's kind of pushed the pendulum back. Now that osteonecrosis of the jaw is sort of waning, and now we see these 2 studies, it's pushing people back to maybe treat people for a bit longer. And that's where I think that in between has landed at roughly 2 years of monthly treatment, then every 3 months for the majority of patients. But again, as we've heard beautifully today, it involves a discussion with your treating physician. We've just completed the ASCO, or the American Society of Clinical Oncology, guidelines on the topic, which basically flavors what I've just said. 2 years, then consider dropping down to once every 3 months and reinstituting it at time of relapse.
Can I ask the next question to Dr. Bergstrom? So this is a series of questions, but hopefully I can put it down properly. But it really has to do similarly with what we were just discussing, which is that people are alive for a lot longer, and so they're getting these drugs for a lot longer. And so this pertains really to steroids. So I guess really how long, like why do we use dexamethasone or steroids with all treatments? Does it stop working at some point? And how long can you take it before you run into problems like bone disease? And then with that, why do we sometimes use prednisone as opposed to dexamethasone?
I might have to get you to repeat parts of the question as I
Okay.
go along. So what was the first one?
The first part of the question is, why do we use dexamethasone pretty much with everything else that we give?
So I think a lot of that comes back to the point of using different medications that have very different effects. Dexamethasone is a very effective anti-myeloma agent on its own, and you can, with that high-dose, dreadful pulse dexamethasone that everybody hates, where you take 4 days on and 4 days off, and it's awful, but that is enough in some patients to actually get them to at least a very good partial response. So we know how effective it is because we could see these amazing responses in some patients, but that's at the cost of great toxicity. It does modulate the immune system, so it's an immune suppressive drug, and all blood cancers basically have some association with the immune system. So we really use steroids in some capacity with actually most blood cancers. So it's part of lymphoma therapy, it's part of myeloma therapy, because it's a very effective anti-cancer agent in these conditions. So it is actually very effective treatment directly. And it actually also counters some of the side effects of treatment as well. So, often nausea or decreased appetite can come along with cancer treatments, as anybody who's been on any amount of steroid knows. It drives your appetite and can counter nausea quite nicely. So it does counter some of the side effects of therapy. So it has some value that way as well, and probably has what we call a synergistic effect. In fact, a lot of these medications probably have a synergistic effect where not only does the one do something that the other drug can't do, but they probably do a better job, better together. They do a better job together than they would separately. And so it enhances probably the effect of these other medications as well. So multiple reasons why steroids are involved in virtually all of the protocols, because they do make them better, but at a cost for sure.
And so that leads to the second question, like how long can you be on steroids for in terms of efficacy, but also in terms of dealing with the side effect issues?
So for efficacy, I think that question is challenging to answer because it's the same as all of the other medications, and that some people seem to maintain a response for a long time, and some people probably do lose their response. And you only really know by watching over time and seeing, does that responsiveness seem to go down or not? And because it's used in combination with almost everything, sometimes it's hard to tell which one is losing more of its effect at a given time. But yes, over time it certainly loses its effect in the sense that everything else does as well. And we know that because otherwise we would just keep people with myeloma alive forever just by adding more and more and more steroids, and so obviously that's not effective. At some point we lose some of that effectiveness. As far as what it does to your body, though, I mean, certainly some people seem to manage to tolerate a lot of steroids for a long time, and it doesn't seem to have as many negative effects, and other people have severe side effects, sometimes even early on. There's the short-term side effects of therapy that all of you who have been on steroids know, these the irritability, lack of sleep, the mood swings that can happen with it. It can be very irritating to your gut. Blood sugars, many of our patients are diabetics if you look at the age group. So that can be a real issue, and it can actually be damaging to your bones over time. So there's short-term and there's cataracts, bruising, as I'm sure many of you notice. So there's long-term and short-term side effects of steroids. So the longer the duration of steroid therapy that you're on, certainly that's an issue. And then with dexamethasone, more than prednisone is also the risk of blood clots. We add that to Revlimid, and of course you have myeloma, which gives blood clots, Revlimids, which can cause blood clots, and dexamethasone, which can cause blood clots. So we are very acutely aware of these toxicities, and that is why we watch our patients so closely and why we are constantly in communication with patients about how they're doing with all these potential side effects. We're monitoring for these things, because if there's issues, sometimes, yes, we have to decrease the dose of steroid or maybe even take it out of therapy entirely.
Can I add one thing to that, Kevin? Sometimes the analogy I give to patients to help them understand, I think of steroids as the booster rockets on the side of the shuttle when it takes off, right? It's particularly effective early on. I mean, probably the greatest benefit of steroid is in the first 2 months of any regimen, maybe prolonging that as long as 6 months. And then eventually those booster rockets fall off. So I speak to a lot of patients who have challenges with steroids saying, let's try and get you through these first 2 months, because that's when it's going to give the lenalidomide or the pomalidomide or whatever else the greatest kick, and especially the MIDE drugs, right? The immunomodulatory drugs seem to be a little bit more steroid dependent than the MABs or MIBs. And then at that point we reassess, saying, I would like to keep you on as little as possible to keep the disease under control, but knowing that in the long term, as you beautifully said, cataracts, blood sugar, blood pressure. I mean, if you were designing a drug to cause long-term side effects, you design steroids, right? I mean, it's tragic in one respect, but yet so helpful. So that in future, if we need another kick, we can add some more booster rockets to your next shuttle mission. But that I try as much as possible not to leave patients on long-term steroids, because it inevitably accumulates and causes trouble.
And with that in mind, this goes to the third question, or third in the series, is the issue of prednisone. Why is prednisone used sometimes, and is it as effective as dexamethasone?
So I think the general consensus would probably be no, not as effective, and that's why dexamethasone is used preferentially over prednisone. But the toxicities are also a little bit higher, so there's a higher risk of blood clots. It gets more into your central nervous system, where your brain lives.
When you say you mean the dexamethasone,
the
right? Just to clarify.
Sorry, the dexamethasone is more potent in many ways, including getting into your nervous system, and that's why it tends to cause more extremes as far as some of the, irritability, and some people can actually have a frank psychosis, or they are not themselves at all. That can happen with prednisone, but it's more likely to happen with dexamethasone. So it is probably more potent, but then has a little more potent side effect profile as well. So the reason why prednisone is used preferentially in some circumstances, sometimes it's the way it was studied. So the whole idea of melphalan and prednisone versus melphalan and dexamethasone, well, melphalan and prednisone was put together, and that's what most of the studies were. So I think that just gets used that way because that's how people know to use it. So some of it has to do with the protocols, but then sometimes we will certainly use prednisone if we think there are reasons it might be challenging to use dexamethasone. So if once a week's dexamethasone is going to play havoc with the blood sugars of somebody who's on diabetes, it might be easier for them to manage their diabetes if we use a lower dose of prednisone on alternating days. So that might be something that would come into our decision. Or somebody who's very frail and elderly, we know dexamethasone is probably going to be really hard to tolerate. Prednisone will probably still be effective, maybe not as powerfully effective, but much more tolerable. And I kind of tell some of my patients who are kind of right on that threshold of maybe they can tolerate it, maybe they can't. And they say, well, I want you to keep me, I want to take everything that you can give me to keep me alive as long as possible. And if I go back on my therapy, my myeloma won't stay under control. And I kind of say, well, if I kill you with therapy, even if I fixed your myeloma, I haven't put you any further ahead. It kind of puts it in a different perspective. So if we think the dexamethasone is too toxic, the prednisone will still help and can be quite effective and is usually a bit easier to handle. So that's when we would generally use maybe prednisone over dex.
So thank you very much. That was a very, 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 very good answer. I'm just going to pass the next question to Chris, Dr. Venner. This is something that we just were, I guess, chit-chatting on the side about. MRD testing. We hear a lot about it. Is it happening in Canada, and where in Canada if it is, and where is the role of this currently?
So that's another really good question. It's gaining a lot of traction in the international community, predominantly because we see it as a very, very important predictive tool to get a better idea of how well a patient might do if they achieve that endpoint. So basically, achieving MRD negativity, the best way to think about it is that's the lowest point we feel we can get a patient, beyond which we can really detect with really, really, really sensitive techniques. So it's a really minimal, teeny tiny disease burden. I would be cautious to say that there probably is a fraction of patients that achieve MRD that are quote unquote cured, or at least they have so little disease left over that it will take so long for it to come back that they may lead out their normal life expectancy as a result, depending on when their disease is diagnosed. Now, I say that with great caution because MRD has not been around for long enough for us to really have those long-term follow-up studies to truly get an idea of if you achieve MRD negativity, how long can your disease remain in control. But at least it's nice to say that we are in a position where we can ask those questions because we have the technology to do it. And by we have the technology to do it, I mean the royal we, but not necessarily we in Canada. There's not that many places in Canada that do it. And if your physician is able to access this, it's either because their own local lab, and by that I mean research lab, has some interest in it, or you might be sending your sample away to the cost of about $1,000 a test to get it done outside of whatever province you live in. So it's not really widely available in most labs quite yet. The only other thing that I would say with respect to MRD, and it's an unanswered question at this point, but there's this sort of movement afoot to say if you achieve that really deep endpoint, is there the ability to potentially stop therapy on some of those patients? We don't have trials yet that can answer that question right now, but there are certainly trials that are being designed to look at that question. And it's something that is important for us in Canada because there may be a proportion of patients that we don't need to continue on expensive therapy. So from an individual patient's perspective, this means you get to stop treatment, and in many respects, the best treatment is no treatment. From the provincial healthcare systems at large, this is an important question because there may be a proportion of patients they don't have to pay for more therapy on. It's a very long-winded answer, but the short answer is we don't have MRD testing widely available, but it's something that I think that we would like, and I think it may provide some really important insights into the disease. But it's not for every patient. So.
Maybe I could just ask you a very quick question then. Do you know any center in Canada that does MRD routinely at the level that's currently being published?
No. So our colleagues in Calgary who are not here to defend themselves, they do flow cytometry, but it's not to the published international standard as yet. We have our colleagues at Princess Margaret Hospital who are working towards that, and they have been doing the flow cytometry for our prior MCRN 001 study, and we'll be looking at it as part of the M4 study. But those are also, again, still done in the context of a research study, so patients off study are not getting that testing done. The one other thing that I'll mention too is to say that doing the MRD test is not required in every single patient. So you need to think of it as sort of decreasing levels of disease burden, but if you finish your transplant and you have achieved a very good partial response, which is still a very important endpoint to achieve, and that's a 90% drop in your monoclonal protein level, you still have very easily detectable disease by a simple blood test. So in those situations, doing MRD is not necessarily required, and in fact, that even if you did that MRD bone marrow test, because it does require another bone marrow, unfortunately, if you did it and you were only in a VGPR, it's not going to really add much, and it's not part of even the IMWG published criteria for true MRD negativity. So it's still, as yet, especially with Canadian-based therapies, it's still a minority of patients that we would need to do that test in anyway. So.
The next question I'm just going to give to Joe, Dr. McHale. The next question will be for Dr. McHale, just because he has published on this. High-risk disease, particularly 17P, and maybe gain of 1Q. Do you approach them differently? And maybe you can also speak to some recent data about what 17P and how not everybody's the same as well, too.
Yeah, so I think I sort of intimated earlier that myeloma is not really one disease that everybody who has it shares it, unfortunately. There's probably almost 6 distinct biological entities. And we know at one end of that spectrum, there is a very high-risk group. And what we mean by high risk is usually that there tends to be a lot of disease burden, that paradoxically it may initially respond to treatment, but it comes back quickly. That's really the hallmark of high-risk disease, that unfortunately people have short-term remissions. And we learned this. We learned through the Arkansas experiment where, they treated patients very, very aggressively. The highest risk group to be in were those patients who unfortunately got the deepest of responses, and sometimes even MRD negativity, believe it or not, but then whose disease came back quickly, right? Sometimes I've said, is it better to have loved and lost love than to have never loved at all, And I don't mean that facetiously. I just mean that those patients who had that really deep response and then relapsed quickly, unfortunately fared worse than those who had never achieved a complete remission. That's the danger of MRD testing. That's a whole other subject, and I think Chris handled it very well. That we want to be careful that we don't tell our patients you have to get into an MRD negativity, because it's dangerous actually to over-treat people to an artificial response. When I interrogate the long-term database at Mayo Clinic, or did when I was there, 15% of patients who live over 15 years with the drug, and this is back in the day, with the disease rather, have never had a complete remission. So don't think that complete remission is the holy grail for everybody. But what we've learned about that high-risk cohort in something that's practical for you to hear today is that if someone is identified with high-risk disease, which is usually by a genetic marker of 17p deletion, which was mentioned, or an abnormality in chromosome number 1. 17p deletion just means, by the way, that in your 17th chromosome, you have what's called a P and a Q arm. The P arm is deleted. There's a gene there that seems to be important. We jokingly in Arizona call it the Sheriff Joe gene. Yeah, that's not awkward, right? But it's the gene that is meant to keep order and meant to keep the cells in line. And when that's gone, when the cat's away, the mouse will play, the disease starts to be able to be more aggressive. What we've learned in that group, and there are other ways to define high-risk disease now with other even biological or simple chemistry tests like LDH. What we've learned in that group is two things essentially. One, they should, as much as possible, be given combination-like treatments because that disease is probably not going to be held down by one drug. So even things like Cyborg-D and so on, where we're using multiple drugs together, is more effective. And secondly, that depth of response that they achieve is really important, not only to get there, but to keep there. That high-risk patient is less likely, honestly, to get a drug holiday. They're likely going to have to stay on treatment longer because we've learned that if we take our foot off the gas, if we ease off too much, the disease comes back very rapidly and sometimes can come back out of control. So if you're here today and unfortunately have been diagnosed with high-risk disease, it doesn't necessarily mean it's the very end. It just we need to take a more aggressive strategy to treat you with combination drugs for longer to maintain your remission more aggressively, as opposed to the patient who we might be able to say, oh, you've got lower risk disease, we can maybe give you a drug holiday for a year or two before your disease comes back.
Thank you, Joe. I know that time is running out, but there's actually two questions here which I think are really, really important for people to hear. The first is the database, Chris. I think that understandably people sitting in this room are wondering about how to either contribute to the database or the issue of privacy about your information on the database. So really the question is, like, how do we capture the data in terms of the process of getting a person on the database? And maybe you could speak to the issue of consent, privacy, and how people could jump on the database if they wanted to be a part of it.
So I would hope that everybody agrees, but I have obviously a one-sided view of that. But so the way to participate obviously is you need to be treated or have some affiliation to one of the centers that we described. Every province is a little bit different. So in Alberta, if you have myeloma and you live north, or Red Deer and north, then you'll probably see myself or my colleague Dr. Irwin Sandhu as your main myeloma doctor at least once, in your myeloma career, probably more than that. But and in that way, we have an opportunity to consent you as a patient. In Calgary, it would be somewhat similar, although they did manage to recruit a few more doctors in Calgary, even though it's the same number of patients that we see. But I'll leave that for another day to discuss. So there's a sort of a centralized intake there. For some of the smaller centers, though, and especially in places like Ontario, where things are a little bit more fractured and there are more community-based therapy, there may not be an immediate opportunity to participate. However, there's still often some sort of a tie to some of the big centers. So, for example, if you're transplanted in Ontario, many patients will go through Princess Margaret Hospital or Ottawa. So there's an opportunity to have had that chat. So there's lots of ways to get in there, and I don't think that anybody would ever, at any of those sites, would ever turn you away if you were never seen at those sites, but you really felt that it was important to have your information included. I'm sure that they would be able to speak with you over the phone or in some way, shape, or form go through the consent process. It's very easy consent process. There's nothing fancy with it. It's just agreeing to have your data used in an anonymized way at the national level. And if you do have any other questions, feel free to reach out to me through Myeloma Canada. I'm happy to try and link people in with whichever center they live or that they're the closest to. The flip side of that is, is there any disadvantage to having that data collected, and what is the level of privacy and things that are there? So in the main database, the national database that's housed at Princess Margaret Hospital, all of those numbers or that patient level data is anonymized. So there is no way for us, other than the key that would rest at the individual site contributing that data, there's no way for the national data set to have any link to a name. Even things like your date of birth have to be changed a little bit, so we can't have day of birth in there. It's just month and year. So we take as many steps as we can to de-identify that, but still be able to retain the important outcomes ultimately, so that your information is protected. And again, we also have the oversight of the steering committee that will ensure that we have complete control over any data that would leave our sort of central review and our purview there. So I hope that answers the question. Is there any other sort of specific questions that I didn't touch upon there, though?
I guess one just quick yes or no questions. Are patients given surveys, or is this just purely data that's captured from the institution themselves?
So the patients are not given surveys per se. This is all data that's captured is data that we would normally be capturing through the course of our regular clinic visits and our quote-unquote standard of care.
Okay.
There may be some opportunities down the line to do those types of sort of patient-reported outcomes, quality of life type things, but those would be specific prospective studies that we would want to enter in later on, but not necessarily immediately captured.
Last question for Dr. Bergstrom. Can patients go to other provinces to participate in clinical trials?
So that's absolutely a possibility, and that can happen. The only issue I think that probably prevents a lot of patients from being able to go outside for clinical trials. So the process for that is generally, and I've clearly done this a few times because I am in a smaller province, is you generally contact, we'll generally contact that site to find out if the study is open and accepting patients and what kind of availability the physicians who are running the study at that site have to see the patients. And then we'll look at making an arrangement to make a referral to that site for an assessment. Because studies are by definition not something that is generally standard of care, the studies are what get things to being standard of care, but they're not standard of care yet. They're usually not funded by provincial drug plans for all of the patient-associated costs. So the costs of the study itself, as far as the drug, the visits, those kind of things that are direct study costs are generally covered through the study. But when it comes to the patient costs, for instance, accommodation, travel back and forth to that province, the associated costs not covered by the study, they'll generally not be covered by your provincial drug plan, and many insurances will not cover that again because it's not considered standard of care. So there is often a significant patient commitment that is required to be part of these clinical trials. Even within provinces, Chris lives in Alberta, we have a huge care area. I trained in Edmonton actually just before Chris did, even though I'm sure I'm younger. No, I'm not. But you know, we covered northern Alberta, but also some other parts like Northwest Territories and things. So we have a huge area that we covered territorial-wise. I'm in Newfoundland. We are in St. John's, which is basically if you go any further east, you fall into the ocean. You have to swim across to England. So like we are as far as you can get. Most of the province does live on the Avalon, which is in the east, but we have many, many patients who are across the island, and we also have Labrador, which is part of our jurisdiction. Well, you can imagine a patient who lives in Labrador cannot come down once a month for a clinical trial assessment. So even within Newfoundland, we have trouble having patients in for trial, even though a lot of their transportation and things are covered. Just the patient commitment that's involved with having to come back and forth for clinical trials is often very large. So each province has to deal with that within their province. There's actually a difference in access to trials within a province. So you can imagine crossing borders to get between provinces for patients who do not maybe have a lot of resource or don't have an ability to leave and go back and forth. It is an issue with access.
Thank you to my panelists. Unfortunately, we don't have any more time. There are a lot of great questions that are here. A number of them will be answered in future sessions, so hopefully you'll get the questions and answers at that time. Of course, I think a lot of my colleagues would be willing to speak to you one-on-one if you have other questions. Thank you.